So you've noticed a decrease in urine output in your patient and you're wondering, should I be worried about this? The answer is yes. Your patient may be experiencing an acute kidney injury. These happen within hours to a day, and if we diagnose it and treat it quickly, we may be able to reverse the cause and restore kidney health. This is Tommie with NurseMinder, and we're going to get into pre-renal failure, one of the categories of acute kidney injury that you need to be watching for as a nurse and a healthcare provider. Now in today's video, we're going to talk about the common causes of pre-renal failure and how to identify that in your patient, looking at some of the stages that you might notice, as well as the common treatments. Now, one of the videos I've done in the past that will help you understand part of the causes of pre-renal failure is that on ACE inhibitors. ACE inhibitors is a classification of drugs that we take, but inside that video, I go over one of the natural physiological things that happen inside our body, the Renin, Angiotensin, Aldosterone pathway. So if you haven't seen that before, do take a watch either before or after to help you understand this piece. Now, when it comes to the blood flow to the kidneys, there's 4 categories we're going to look at: loss, pump, leaking, and blocked. Is there a problem with the volume of fluid because there's a lack of it? What does that mean? Perhaps you have a patient that has been chronically vomiting, diarrhea, sweating. That fluid that's actually meant to go into the body and be used in different ways is coming out in places it shouldn't. The other thing is, are they hemorrhaging? Is there blood loss that you can physically see, or there's something going on internally? If we have a loss of volume of fluid, the kidneys will be hypoperfused. That's one category to check. The second one is the pump itself, the heart. Now, the heart will send 25% of its blood right to the kidneys for filtering. How cool is that, right? Now, when it comes to the heart, there's many things that affect its functioning. We have an electrical system. So if the electrical system's not firing and we have an arrhythmia, that might be affecting the volume that reaches the kidney. If there's an injury to the muscles, like as in a cardiac event, a myocardial infarction, that affects the heart. Like typically it would contract, and now we've only got like 3 of it, maybe a 30% of the muscles working. That's going to affect how much blood is getting to the heart, to the kidneys. How much blood is getting to the kidneys. Congestive heart failure, pulmonary edema, and cardiogenic shock, all things that might be impacting the pump. The third category is leaking. As the blood is making its way to the kidney, is it finding different places to go? It's leaking out of the vessel when it should be inside the vessel. We call this peripheral vascular resistance. Typically, the blood is, pretty neatly contained in there, but if it's leaking out, perhaps you've got an anaphylactic situation, or your patient's in septic shock, where it is actually impacting the entire system, and fluids are going now from the vessels into the cells and into the cavities of the body, creating a lot of swelling. Then it cannot go to the kidneys. So that's another place to look. And then the last category is it blocked? Is there a blockage in this artery that is preventing blood flow to the kidney? An embolism, a thrombosis, something that's actually like a beaver dam. Poof, right there. Blood's not coming through, kidney's not getting perfused. Now, another important thing to remember is your medication. So when you're doing your patient evaluation and you're getting their medical history, you're paying attention to past cardiac history, you want to make sure you understand that. The other thing is to look at their medications. So are they on diuretics? Are they taking ACE inhibitors? Because these 2 together are a likely combination that's causing your pre-renal failure. NSAIDs. Has your patient gone for contrast? This is one of the reasons why we're checking for urinary output post-diagnostic imaging, is to make sure the contrast hasn't created a challenge for the kidneys. Okay, so now that we looked at some of the things that we need to be looking for and considering in terms of contributors to acute renal failure and pre-renal failure specifically, let's look at the stages. Now, as you can see, there's 3 stages, and I'm going to be including this document in the link below so you can grab it. But stage 1 is looking at an elevation in creatinine of 1.5 to 1.9 times baseline, a rise in serum creatinine of greater than or equal to 0.3 milligrams per deciliters, and a decrease in urine output to 0.5 milos per kilo per hour for 6 to 12 hours. Now, stage 2, you're going to see that rise in creatinine go to 2 to 2.9 times baseline, and you're going to see that decline in urine output extend past that 12 hours. In stage 3, we're continuing to see a rise in serum creatinine. We're continuing to see a decrease in urinary output to 0.3 milos or less per kilo per hour for greater than or equal to 24 hours. And they can also be anuric, which means they haven't peed for greater than or equal to 12 hours. So now when it comes to treating, we're going to look at those same 4 categories of loss, pump, leak, and block. If it is a loss of fluids, we want to replace those fluids. So it could be a normal saline, it could be a blood infusion. And so that might be part of your treatment plan, and recognizing that if there's a pump problem as a result, or if there is a pump that is contributing to the hypoperfusion of the kidney, we need to be careful as to how fast and how much fluid we give. Okay. Second thing is that if it is the pump, we're going to be doing an ECG first of all to identify where the cause is. So if it's a cardiac infarction, myocardial infarction, or an arrhythmia, that's going to determine our treatment ahead. So medications are likely to be a part of your treatment plan. If it's a leak, we got those fluids seeping out of the vessels, albumin will pull it back in and allow it to go back towards the kidney. So an albumin infusion might be likely. And if it's a block, we need to remove that clot, and that could involve a few different treatment methods. What's important to remember about pre-renal kidney failure is that it has everything to do with flow to the kidney, everything that's happening above. So this is our zone of interest and above. So what does that mean? The urine that does get to the kidneys is going to be processed per usual. So when you have your urine in a jar and you're sending it for urinalysis, that urinalysis will come back normal because the fluid that hits the kidney is coming out as it should. That's it for me. This is Tommie with NurseMinder. Be sure to subscribe to this channel and share it with your friends, and contribute to the content below by sharing your comments. There is a lot more we could talk about here, but I wanted to keep it short to give you the insights for the pre-renal failure.